Camille, thank you so much for joining us today to talk about your paper and specifically the ethical aspects of the role of social and behavioral sciences in sort of advancing the vision for precision health. I think this is a very timely topic. It's been important for a long time. It will continue to be important, but I think this is a great time to be having this conversation. Before I hand over to you and ask you to introduce yourself to folks on the line, let me just whiz through some housekeeping for folks who haven't attended one of our Journal Club sessions before. So just a quick note, I always like to disclose we are recording this, so for folks who couldn't attend live today, they will have access to this afterwards. Slides and recordings will also be sort of available on the website, and we'll keep you posted there. The way this works is Camille will give an overview of the paper, teasing out a few key talking points for everyone, and then we'll throw it open to discussion. I love our Journal Club sessions. They are very much discussion based. So for folks who have dialed in, right now you're muted. As Camille wraps up her presentation, I'll unmute everyone. You can either call out your question. We keep these group sizes quite intimate to really allow for organic conversation. Or you can raise your hand and I can call on you. Or if you are somewhere that's not amenable to a microphone, please feel free to type your questions into the chat. So with that, Camille, let me hand over to you. I'll man the slides. You walk me through it, and I look forward to a great discussion.
Thank you, Jen. So we, just kind of to give you some background, I worked on this paper with a colleague, Eric Heckler, who I've worked with for probably close to 6 years. He is the director of the Center for Wireless and Population Health Systems at UCSD. And he, along with Jasmine Tiro, who is at UT Southwestern Medical Center in Dallas, and Christine Hunter, who is with the NIH Office of Behavioral and Social Science Research, back in 2017, the Society for Behavioral Medicine was really interested in what was taking shape with precision medicine. And so back in 2015, Barack Obama launched the Precision Medicine Initiative with a goal of curing disease and giving us all access to personalized information. The idea was to keep ourselves and our families healthier. And, you know, shortly thereafter, in the New England Journal of Medicine, Francis Collins and Harold Vermis wrote a perspective on this, and they were really describing the vision of precision medicine, really emphasizing the molecular characterization of illness and how we could really use actionable biomarkers to support individualized treatment. But again, the focus was on treatment, and those of us in the behavioral and social sciences, and particularly those of us in public health, were really kind of sitting back thinking, what does this really mean for the future of behavioral and social sciences? Is this all going to mean that omics is the answer? And as we were talking about this, we were really thinking about, well, is it precision medicine, or should we be thinking more broadly about this concept of precision health? And if we start reframing the language, what would this look like? And so part of the goal of precision health, as we're talking about it, is unifying. It's a unifying approach, basically, that takes the whole spectrum of health promotion, disease prevention, diagnostics, as well as treatment interventions, and looking at this entire spectrum of health rather than just the treatment and the disease state. So what this means is that we're not just looking at symptoms, but we're looking at not only the targeted genetic pieces, the biological pieces, but we're really looking also at environmental, social, and behavioral determinants of health. And this was really fascinating to me because I started working on the Precision Medicine Initiative, the All of Us research program, back in 2017 when it first got funded. I joined the team at Scripps and really was thinking about, this is so exciting because this is taking all different kinds of information about people. And about the same time, a paper came out in the Hastings Center report, which is a really prominent bioethics journal. And it was written by Maya Sabatello and Paul Applebaum, and it was labeled, or it was called The Precision Nation. And the cover was just, I'm trying to remember the cover, but it showed like this river of blood and people like all around the picture. And I read this and I thought, well, this is fascinating. But how they framed it was, and I'll read this, it's a quote, working to build a cohort Of 1 million volunteers for genomic research, the Precision Medicine Initiative promotes what might be termed genomic citizenship, a vision of active, informed public participation in genomic research with an attendant right and obligations. What are the challenges to meeting this goal and ensuring that the initiative serves the public good? And when I read that, I thought, that's not what I see this as being. This is so much more than a genomic study. And so I was just really taken aback by that. But about the same time, actually a few months before that was published, my colleagues in the Society of Behavioral Medicine, including the co-authors, decided we needed to have a debate, and we needed to have a public debate about, will the emphasis on the omics of precision medicine potentially compromise public health? And this debate was so fascinating. It occurred at the meeting in San Diego, California in 2017. And it was a hot topic, and people were actually worried, is all the funding going to go into this omic research? And in this paper that Maya and Paul wrote, the way that I read it, the framing of behavioral and social sciences was basically an accent to what they could learn from genomic data. And what we were seeing is that if we don't get at the root cause of what kinds of behaviors are leading to these diseases, we've lost an incredible amount of power of changing human behavior so that we could, in fact, realize precision health. And, so in this paper, we describe dynamic linkages between research and practice, as well as medicine, population health, and public health. We're looking at and in this slide that you're seeing, one of the key things that has changed so much over the past, decade has been technology. And so because of the wearable sensors, the portable tech, social media, and the ability to deliver interventions using social media platforms, we have all of these new digital health research platforms. So this is an incredibly new ecosystem that we're working from. Because we have these new technologies, my colleagues who are methods people have really started looking at how can we use different kinds of methodologies to study human behavior in real time, minute by minute, at an individual level. So these things that we call just-in-time adaptive interventions are really N-of-1 studies that are being designed so that we can see what an individual is doing in the course of their day and delivering interventions in moment-by-moment sequences. So when I was a part of the Science of Behavior Change meeting on how do we apply the rules of registering a clinical trial to behavioral sciences, any intervention should be a registered trial. The language was unclear, and so the Science of Behavior Change group convened a workshop at NIH a couple summers ago. I think it was back in 2017, where every single agency came together to come up with how do we define when somebody not only needs to register, but when they need to amend their registration. And what was so fascinating at that time is that people like Bonnie Spring were in the room, and they were saying, but our interventions change. They can change minute by minute, day to day. It depends on the person, the context, and the tools, and the goal. So anyway, these new methods have just been really key to starting to understand behavior change. And so, when we talk about research methods, the optimization trials that I mentioned, just-in-time adaptive interventions, single case experimental N-of-1 designs, we've been doing a lot of work on an N-of-1, and so, whether it is, very small scale N-of-1 where you're doing crossover design studies with one patient, with one issue at one time, versus, participant-led research studies where you have a cohort of people that are trying to better understand their own biology and how their behaviors influence their health. Science is looking really different now. And so I think a key point, and Jen, I think if you could go on to the next slide, what we're seeing here is a shift in our paradigm from this traditional approach where, You know, we're using randomized clinical trials with a lot of people who represent a lot of people, but not necessarily that one individual, where we start with producing transportable knowledge. We then disseminate findings into clinics and communities with the hope of helping an individual. So flipping that with the idea of how do we help this individual, and identify clusters of people and change mechanisms where we can test these processes with people in real time and in partnership with these people. It's not like we're doing it to them, but with them. And this then can produce this transportable knowledge, because it's not only something that can be generalizable, but it's really about what does that mean for that individual at that time. What we did in this paper that I think is, you know, to unpack it, and like I was mentioning to Jen, this was a pretty heavy paper that we were writing, and it took a couple years to get it to the point where it could be published, and that was after cutting it extensively, and it's still incredibly long. My focus in this paper was on the ethics component of it, but what we did with this paper is we talked about new interventions, we talked about accelerating linkages between research and practice in real world contexts, and then we looked at 3 challenges: knowledge curation, ethical conduct, and implementation. Equitable implementation, and that's a key, because we don't want people to get left behind, because technology is not accessible to everybody and it's not being tested on everybody. And so ethical and accessible implementation is really important, or we're going to exacerbate health disparities, hopefully unintentionally, but if we're not aware of the potential to do this, we will walk right into that. So my focus in this paper was really on the ethical component, and you know, thinking about how do we do our ethical principles that we've carried forward of respect for persons, beneficence, and justice. And I'm talking about research ethics, not clinical ethics. Can these be brought forward, and are they still relevant? And are they still relevant with respect to, can we still obtain informed consent? And I wrote a paper about this a couple years ago with Gary Wolf and Azure Grant on participant-led research. These were people that wanted to study themselves. They did it as a group. And Gary asked me if I could be involved as to help them with the ethical pathway, because there was no requirement to have an IRB involved. There were people who were not trained researchers that wanted to study themselves. There was a goal of looking at blood lipids. So there was a question about, how do my blood lipids change when? And everyone had their own question about when I exercise, when I eat a keto diet, when I'm menstruating, when I have stress in my life. So everyone had their own question, but we wanted to have a group consent process. So we talked about what the protocol would look like and what they needed to be aware of in terms of risk management, potential for benefit. And so as a group, we collectively had this discussion, because for a participant-led study, there's no requirement for informed consent. How does a person consent themselves? And what are the potential pressures that may influence a person's ability to voluntarily participate in a group self-study? So, I mean, the questions that are coming up now are unique. IRBs don't know how to handle them, because these are really novel kinds of questions. Even when traditional researchers are doing N-of-1 studies or talking about just-in-time adaptive interventions, how does that look to an IRB that is saying, can we get consent from a person if you're going to be changing the intervention every day? You know, what does that mean? How does that person understand what this is about? So I would posit that the informed consent that we know now needs to change. I think that risk analysis is really going to be tricky, because there's a lot of unknown unknowns. We don't really have the answers yet. And whereas in a traditional research study, you know, where we have people exercising to exhaustion, VO2 max testing, we can quantify that. We can say 1 in 12,000 people who are healthy generally will have a cardiac event as a result of doing VO2 max testing. We can say that. We can't say that with a lot of these other things. With social media studies, you know, what happens when we deploy an intervention, and let's just say it's for college age weight loss. We have a cohort of students, they've enrolled online, the intervention is being assigned to some, but not all. And then Facebook changes their terms of service. You know, what does that mean for informed consent and privacy and data sharing and things that do influence risk? And then the issue of justice is critical, because if we're only engaging people of a certain demographic, and I can tell you, working with older adults right now, they're not included in so many of these studies. And right now, their access to technology is so limited. And we also have written a paper on the fact that they don't even get consulted when somebody's making a tool that they could potentially use. So with Fitbit, for example, we have had to take the reading that comes out on the Fitbit screen and completely retool it so that it can be visible and meaningful for an older adult to be able to digest that information and make sense of it for them. So I think we have a lot of challenges. I really think unless we engage behavioral sciences and social sciences in any of these studies, we're really going to be at a loss and only seeing kind of a myopic view. And I'll leave it at that. But, you know, in addition to behavioral and social scientists being critical voices in this process, we also need to be more active of engaging a health technology ethicist in these questions. Like I said, IRBs are stretched pretty thin. And in many cases, the IRBs are not even engaged because the regulations don't cover the activity. And so, you know, only when you receive funding from Health and Human Services and your institution has signed an agreement, a federal-wide assurance saying that they will comply with federal rules for human research protections, unless they're in that camp or covered by FDA, there are no rules for human research protections. And so you then have to trust that whatever the entity is, you know, it could be an organization, you know, there are some very reputable health technology companies that have been acculturated by academics who have had IRB involvement for many, many years. And they're kind of bringing that forward. Even if they're doing it in a different way, they're still thinking very carefully about the ethics of human subjects research, but they're not mandated. So a lot of that's voluntary. And I'll stop there, Jen, and see if you'd like to, you know, move it forward to questions.
Fantastic. Yes, I'm just going through and unmuting folks on the line. So definitely dive in or raise your hand if you'd like me to call on you. I have a laundry list of questions here that I'd be thrilled to pose, but I want to pause for a second and just see if there's anyone on the line who'd like to get us started. So I'm hoping that, Michelle, I'm going to call on you a little bit because I'm thrilled you're here. I know that you're working on the All of Us study right now, and I suspect that some of Camille's really excellent points sort of jived with a lot of the challenges you're thinking about right now. Camille, I wonder if I can talk to you a little bit about or ask you to expand on.
Hold on.
Hi, Michelle.
Hi, sorry. Just trying to close the doors and get my kid to leave me alone for a moment.
I feel like this is the new world that we're all experiencing right now. Thank you, Michelle. I appreciate you diving in. Go ahead, ask your question.
Yeah, so Camille, I'm so glad to connect with you. I have so many questions, but my main question is right now, you know, I'm kind of trying to work at that intersection of technology and social justice and leveraging technology to really push forward. You know, so COVID is a great example of, you know, if wearables are able to tell you if you've been exposed but you're not symptomatic yet, and we decide to, if that technology ends up, you know, being fully developed and realized, and we decide to roll that out, but we don't actually have the adequate penetrance in the communities that actually need it the most. I'm trying to figure out and get a feel for what are the disparities that are existing in terms of who's using these devices, what are the kind of aspects of cultural diversity or other socioeconomic factors that are preventing their use? And how can we start to do research to push that forward so that, as technology and health get more and more entwined, especially with telemedicine, becoming more online and adopted in this scenario, how do we make sure we leave people behind, and what is behind?
Michelle, that's a really great question. I'm so glad you're asking it. And Jen, did you say she's with All of Us research program? Michelle, are you?
Yeah, so I'm a Presidential Innovation Fellow, currently detailed to the All of Us research program. So I've been with the program since about October, and I've been specifically helping them think through what to do with the Fitbit data and other digital health technologies.
Oh, that's really great. We did a study several years ago, and it was when I was still working with All of Us, and but it wasn't connected with that study. It was actually looking, because San Diego County, where I live, is incredibly diverse. We have a very large refugee population, Latino population, and a second largest Native Hawaiian Pacific Islander population, next to LA. So I was working with colleagues who were doing research, community-based participatory research in each of these communities using sensor technologies. And I asked them, I said, I'd really like to know what your communities think of these different kinds of technologies, GPS, wearable cameras, fitness monitors, and it was so uniquely different across these groups. So the Native Hawaiian Pacific Islanders were really concerned about GPS tracking, wanting to know who wants to know where I am, and it would not buy into that. And this was, again, 3 or 4 years ago. Latino population was concerned about legal status. We're on the border. Easily could be identified. I mean, San Diego County was the 3rd largest area for ICE deportations in the last couple years. And so our Latino community does not want to buy into using these kind of tools because they don't trust the government. And the other group was the refugees. And there was an assumption that they would wear a wrist-worn device. And so even with community-based participatory research, the people in the community said, oh, sure, we'll wear that. Maybe they were only offered one option, and then they agreed because people are agreeable, and then they never wore it. And the reason they never wore it, and this was funny because my colleague went back to get the devices and found no data on anything, no data. And it turned out because of their religious practices, it just got in their way. They said, if you could have given us a device that we could clip on our shirt or on our waistband, that would have worked. But the wrist-worn device was a deal breaker. And I think that, and with the older adults, as I mentioned to you, they're scared of technology. They're scared of privacy violations. They don't want to, some of them just don't want to learn because it's too complicated. If you try to look at terms of service, not only are those horrible to look at, but their font size is tiny. And even with corrective glasses, people who are over 65 have trouble seeing a 7 or 8 point font. And then they don't know what the words mean. Things like Bluetooth and data sharing. How is that different than donating? How is it different than giving? And who's going to, it's like there's so many complexities that my work now has been like for the past 5 weeks, I've been doing focus groups every week with people in a retirement community that are living independently. And the challenge of even getting to those who were able to get on Zoom left a lot of people behind. And so I'm really worried about leaving people behind. And I think unless, like I've found out so far that half the people in this community don't have access to technology. The only thing they have is a landline. Many of them don't answer that. And so how do we introduce some kind of usable technology? The older adults, like I said, they're not able to understand the feedback that they're getting from the Fitbit device. And so we had to take time to figure out how do we make that meaningful and accessible. So I would do a lot of design work, meaning that I would really find out what their barriers are, what they need, what would work for them. In some cases, they're sharing technology with their family members. They don't own it themselves. They share a phone. Yeah, so I think that taking the time to do the formative research is critical, and it takes time, and it's really important.
Thank you. That's really helpful. I totally agree. It feels like we're in this moment where things are getting rolled out pretty quickly, and there's this like rapid iteration, and I just worry that we're not going to be able to do that kind of a methodical type of an assessment, you know, in fast enough, basically.
So with the digital contact tracing, you know, obviously it's not going to work unless there's adoption. And right now it looks like 4% of even countries that are trusting, or you know, the community trusts them, are not only 4% are adopting, unless it's mandated by the government. And so it's not going to work. And even with the traditional contact tracing, I was talking to my colleagues in the county epidemiology. They say, you know, we find out who's positive, we start calling them, we call them 3 times and they don't answer their phone. And then we send letters. And so traditional contact tracing is also experiencing a lot of challenges. So I think we're in for a rocky road unless we take the time to start talking to people.
Great, thank you.
Fantastic. And I see, Aubrey, you've got your hand raised. You should be fully unmuted if you'd like to ask Camille your question.
Yeah, Camille, this is great. I really appreciate this work, and what you're saying about older adults being left behind and such. I've seen that myself in my own work, but something I was wondering if you had any experience or any comments on was whether training peers within a demographic. So, for example, my grandmother's 84 and is unusually tech savvy. And what I've found is that she's able to teach her peers and kind of lower the overwhelming barrier in ways that I can't quite do. And I was wondering what your thoughts are on, you know, training peers to introduce things within demographics, and whether there's been any success there.
I love that. And, you know, at the end of our focus groups, we ask them to help generate solutions. And this is with the older adults, and this is what they're saying. Can you teach, you know, 5 or 6 of us what we need to know so that we can then host classes? Because I can't come to their facility. I can't go in because they're truly protecting their community. I love that, and it does work. Where I've seen it work really, really well is a community with community health workers and promotoras. I've worked with promotoras for many, many years, and that's just been just a beautiful solution, because we train the promotoras. They take what they learn into their community, whether it's about cardiovascular disease or mental health, or how to use an iPad to do X, Y, or Z. So it is a really good model, and I am definitely wanting to try that out with the older adult community, and I think that it would work really well. And they do know what the traditions are, the customs, the language, the barriers, so much better than I do.
Yeah, they use totally different metaphors. And where I saw it the first time was actually a really long time ago, when I worked in a public library in high school, when we switched over to the digital card catalogs. And, you know, if I was at the desk, you know, anyone who walked into the library, you know, they're not going to use the card catalog. I have to use it. But when the, you know, 80-year-old, you know, senior librarian came out, you know, oh, they couldn't be shown up by Carol, you know, of course they've got to be able to use it themselves. And then you wind up, you know, training a whole community.
Mm-hmm. Yeah, I think it really does work, and it is an investment. So I'm hoping that we'll see some funding that would support that kind of effort, because we're in this for a long haul. This is not, you know, anything related to COVID and the pandemic is not going to go away. And again, these are behavioral interventions. These are, you know, educational interventions. These are not things that we can just fix with genomic data.
And if I can, and then Bernadette, I'll call on you just to connect a few dots. Aubrey, that's such a great question. And Camille, I was excited by your enthusiasm for peer support. Dr. Karen Fortuna, who's at Dartmouth, she does an awful lot of work with the Massachusetts Department of Health. She's actually developed a peer support curriculum, which is available and is being rolled out in some states via Medicaid. It's a really sort of tremendous initiative, and happy to connect some dots there behind the scenes if that's useful. But Aubrey, that was a great question. I really appreciate it. Bernadette, let me call on you next. You should be able to voice your question. Let me know if you...
So, hi Jennifer, hi everyone. So what I just wanted to share my own opinion is the fact that we should remember before the home testing in the diabetic areas become a little bit common, many people also thought it would be something that people cannot master. So I believe it is important to try to get the lessons learned from the diabetes management sector and then maybe incorporate it to what we think might be necessary for clinical trials or for patient management for telemedicine and e-health as such. And last week in Germany, we had the coronavirus tracing app. And although many people were skeptical at the beginning, most skepticism was based on who owns the data. Is it going to be a centralized data collection point? The moment the government could take care of that and everybody knows you are being profiled locally, it works with Bluetooth, and then it was easier for people to, so maybe within 48 hours post-launching, 10 million people had already downloaded the app. So I just believe in the moment people trust, everything is about trust. Who does what with my data? Because many people still have, yes, there will be that technology bias, there will be age group bias, there will be selection bias for specific patients, but all of us know we are moving into a long haul. It's not going to be something that is transitional. I'm sure we are going to see more IE moving forward. But now it is about trying to get in the mindset. But I believe we can learn a lot from the area of diabetes, how they manage to move certain things to be more patient focused.
Thank you. And I think, you know, it's just interesting across cultures, across countries. And I'm going to guess that in Germany, there's a bit more trust than what we see in the US. And discrimination is the fear. People worried about the data being used in a way that is going to harm them more than help them. So, you know, I need to look into the Apple Google platform, but it seems like that is one that is becoming a trusted platform that others are building their apps on. It is going to take some time to build that trust. And I think the same kind of things that we're seeing with some people having certain preferences about their responsibility around mask wearing. And so I think that we're just going to see some diversity in adoption.
May I come in shortly?
I'm sorry, what?
No, so I just wanted to add something because there was also disparity. The majority of people who downloaded the app were Apple users, less were Android. So that aspect of trust is really, really important. I just remember that there was this discussion, we were discussing why is it that many Apple users downloaded the apps, but the Android users are avoiding. And maybe that comes with the image people have with the Apple products, that data is cannot be stolen or cannot be transferred without that there's more data security, probably. Yeah.
That's a really good point, because I think that is an indicator of disparities in social economic status as well.
Bernadette, terrific questions. Thank you so much. Camille, I'm going to give voice to a question that was typed into the chat just in case anyone's just on the phone. So the question is, have there been any thoughts on using community-based recruitment, for example, partnering and working within a community throughout the process, with some of the groups being mentioned to increase participation and applicability of the interventions?
I need to know a little bit more about the context. If we're talking about digital contact tracing, I'm not sure what kind of community recruitment's being done. I know that Jen, you and I are involved in the World Economic Forum, and how the word community engagement is used is very different. And so community in that context is very, high level, diverse groups, community groups. Whereas when I think about community-based recruitment, I'm thinking about engaging communities where health disparities are more prevalent and talking to people that are closer to the ground, people that are working more directly with the promotoras who then have access to, the Latino community in many cases here, or the patient navigators who are working with our Native Hawaiian Pacific Islanders. So I think that even thinking about what community-based recruitment is a question that I didn't have as much before a couple months ago that I do now have. I think community needs to be defined across a large swath, but knowing what we're talking about when we talk about community, I think is a first step. I do think it's really important that the community be involved in these discussions. And not have something done to them or at them, but in concert with them, because, this is a community problem and it really is going to require community solutions. So whoever asked that, thank you.
Terrific. I am going to take an opportunity to ask you a question, Camille. As you were sort of giving your opening remarks around sort of the distinction between precision medicine and precision health, and how it's important to have sort of social and behavioral research in there, and potentially, early on concerns about sort of different omics fields maybe taking up all the oxygen when we think about precision medicine. It was really interesting. You talked a lot about sort of research methods, right? So their methods. And then you talked about the different fields like omics, so on and so forth. And then we spoke about digital. Like, is digital a tool that can power all of these different things? I'm really curious for how you sort of place that in the tapestry of all these different things that we try and do to improve health and improve lives, and how that might help us think about the risk associated with digital and digital tools and the data it generates.
I think that's a really, really great question, and there's a lot of pieces to it. What I've observed, I'm in the Division of Behavioral Medicine in my at my university, which is part of family medicine and public health. And my introduction to digital tools was about 8 years ago, when my colleagues in behavioral medicine wanted to use these digital technologies to study people in the wild. And so this is why I think it is a critical piece to why behavioral sciences is going to be a key player in how precision medicine, precision health moves forward. So what they were doing is, like, up until that point in time, they had to rely on people coming to a lab, behaving in an artificial setting, or telling them answers to questions where they may have had to reflect from 2 weeks ago what they did, or relying that they were keeping their 3-day diet diary accurately. So much is relying on self-report that we were kind of not able to be confident in all cases that what we think was going on was actually happening. So with these digital tools where you have passive sensors that are recording 24/7, they're not, as long as they are tested and they can do objective measurement, you have so much more power to be able to know what people are doing in their everyday lives, and having that individual level data is so much more powerful than a clinical trial where you have averages of a lot of people that may be sort of like that person, but are they really? And can that finding really mean something to this individual? So these digital tools are allowing us to really dial in on an individual, where they are, what they need, what their goals are, what their aspirations are, what success means to that person. And so then you can dial in interventions that help that person reach those goals. So optimizing this so that it actually can happen is what we're starting to study now. We have an R01 that's going to start in July 1st that is really about optimization trials. How do we do N-of-1 research on a larger scale? I don't know if I got to your question, but this is what we're looking at, is really taking these tools and learning what people are doing in their everyday lives 24/7 in a way that's respectful, that is beneficial, that we've really mitigated risk, and that we are reaching all people that potentially could benefit.
You really did answer my question, and I think sort of two things spring to mind. I think one, Bernadette's comment about what can we use from when we've previously deployed these technologies, and I think diabetes is like a great case example. But Camille, I was sort of mentally connecting the dots between your answer and how you talked about transportable knowledge and making sure that it's equitable. And I could sort of see in how you described sort of this new era of digital research, always thinking about the end in mind and actually being able to sort of roll out the findings and the knowledge. I want to ask you to describe RECODE for our colleagues before we break. I want to make sure we do break on time. We try and run these about 45 minutes because I know everyone's back to back these days. But Camille, what you've built at RECODE Health is absolutely extraordinary. And I think that folks on the line might really benefit from knowing about the resources you have. I wonder if you could share a little bit about the center and what you have available to folks working in the space right now.
Thanks so much, Jen. And maybe if you show that last slide that I have up.
Yes.
So I'm the director and co-founder of the Research Center for Optimal Digital Ethics, and our focus is on digital health technologies. And so we're really in the health space. This is a center that the UC San Diego Office of Research has supported over the past 2 years. And what we're trying to do is develop tools that people can use, particularly researchers, helping them sort through what kinds of digital technologies they may want to use in research. So we've created a digital health checklist that helps researchers think through what they need to know with respect to privacy, data management, access and usability, and help them think through risks and benefits. We also have, with Robert Wood Johnson Foundation funding, created the Connected and Open Research Ethics platform, which now has close to 900 global members involved in sharing protocols, sharing consent language. We have a forum where people ask and answer questions. And the other thing that we have is a learning center where we have developed and are now sharing our educational research or resources. And our focus in that has been on non-scientists. So we are trying to build capacity. We started with community health workers by teaching them what the scientific method was and how ethics in research pertains to the scientific work that they were doing, because oftentimes they're partners in research with our academic researchers. And so this is a center where we're doing research on research ethics with a focus on digital health. And we welcome collaborators. We are working across the sector and just are really excited about being a resource for the folks in DIME as well as, you know, across the digital health landscape. So thanks for asking.
Of course, it's such a good resource. And Camille mentioned some of the World Economic Forum's initiatives around using wearables instead of managing pandemics. And actually one of the checklists that Camille referenced is being used as sort of foundational. So it is sort of really ready for implementation if any of you are looking for resources. So Camille, I'll thank you in a minute. What I want to do very quickly is just run through a couple of upcoming events in case it piques the interest of anyone on the line. Our next journal club next month in July is being hosted by Mark Rothstein. This is a really terrific piece that was written and published, I think, only last month, thinking about specifically unregulated health research using these mobile technologies that we've been discussing today. Mark will be available for discussion to really dive into ethical considerations and policy recommendations. So again, a very action-oriented bend to our next journal club. Later this month, we also have our lightning speed session. So this is just a 30-minute session, very sort of hands-on conversation. And we are thrilled to welcome Lynette Dorido, and Jorge Rodriguez. And the focus of this is around actively addressing disparities in digital health and digital solutions and outreach. So it builds really well on the conversation today. So I hope many of you can join us. With that, thank you everyone for being on the line today. This was a terrific discussion. I have some action items. Aubrey, I'm going to connect you and Camille with Karen, so that you can, Karen Fortuna, so you can continue that conversation. And also the slides and the recording will go up on the website so that these resources that Camille, you shared, will be available to everyone. Thank you everyone for terrific questions. And it's always really nice. I still feel we're all quite disconnected. It's lovely to check in with some folks in the community. And Camille, thank you for your hard work and a terrific conversation today.
Thanks so much, Jen, and everybody for attending.
Take care, everyone. Stay safe. Bye-bye.
Bye.
Bye, stay safe. Ciao.